taking an chronic renal failure patient for general surgeries like say hernia or any other surgeries. Okay, so this class will be very superficial and it will be sufficient for postgraduates at DNB who are going to exam. In a fraction of 15 to 20 minutes, we can just get an outline of what everything is going in the system when we are posting a case with renal failure and patient on hemodialysis also. So starting up with some numbers like to what extent people are having this chronic renal failure and how frequently we can encounter. So let's focus on epidemiology. This is the leading public health problem worldwide, and there is a prevalence of around 13.4%. And among this 13.4%, there are people who are requiring renal replacement therapy, RRT also, that is between 5 to 7 million people are on RRT globally. Coming to Indian statistics, it's around 17.2% of our population are having kidney issues. Among them, 6% are having CKD stage 3 or worse, that is they are dependent on hemodialysis. So why this high ratio? Like it's almost 1/3 of our population who are having renal problems are on dialysis only because of delayed what you call evaluation being done, and about 50% of patients, when we are investigating and we're finding out, until then their GFR is dropping around to less than 15%. So initially, if you are able to find with GFR above 40, above 50 or 60, above 60 is almost normal. From 40 to 50 also, we can improve it by giving some medication. But most of our population, we are able to diagnose them only when the GFR is falling less than 15%, 15 ml per hour. In India, there are around 38% increase in population of deaths attributed to kidney failure. So drastical increase. Coming to definition, here there is a number of what you call definitions given in critical care and all. So making things simple, this is classification from National Kidney Foundation Kidney Disease Outcomes Quality Initiative. So they define chronic renal failure as kidney damage for more than 3 months, which could be any structural or functional abnormalities of kidneys, with or without a decrease in GFR, which is manifested by either pathological abnormalities or markers of kidney damage, including abnormalities in the composition of blood, urine, abnormalities in imaging tests. So what he means to say is, any person coming to us with say minimum complaints of decrease in urine output or any other complaints, and when we are doing any structural or functional like imaging or blood test, if you are seeing any abnormalities, this 3 months minimum period is compulsory to categorize him into chronic renal failure. And GFR less than 60 ml per minute per 1.73 meters square for more than 3 months. So he took the cutoff point of 3 months as his criteria. Coming to pathological part, it is an irreversible deterioration in renal function, which classically develops over a period of months to years. It's a slow process, and it takes what we call a lot of changes occur in human body before we are coming to chronic renal failure presents. So like change in architecture of the kidney, and what we call pedal edema. Though pedal edema can be attributed to both cardiac and renal, so long history of pedal edema. So we will be talking about it in rest part of the class. Pathologically, it's a small, scared, shrunken, contracted kidneys with glomerular hypertrophy, and tubular cast will be positive. So these will be presenting in stages. First, there is decrease of renal reserve. That is about out of the millions of nephrons will be present, 50% will be damaged. Then renal insufficiency, frank renal failure, uremia, and finally chronic hemodialysis. Next, staging. Classification of CKD is done based on GFR, and other one is based on albumin. So coming to GFR, it's around 5 grades of Bingian, more than 90%. It's almost what you call damage within normal limits with elevated GFR. 60 to it's not actually 89. It's 60 to 89. Kidney damage with mild decrease in GFR. Stage 3, mild to moderate decrease in GFR. Stage 4, it is 3 given 2 times because it is one is 3 and second one is 3A. So next one is 3A. 3A, the GFR will be 30 to 44 and moderate to severe decrease in GFR. In category 4, it is 15 to 29%. There is severe decrease in GFR. And category 5, it is less than 15%, where it is kidney failure. Coming to albuminuria status. So here we come across albumin excretion rate and albumin to creatinine ratio. So it is categorized into A1, A2, A3, where in A1 you will be having albumin excretion rate less than 30 mg per last 24 hours and albumin creatinine ratio of less than 30, which is normal to minimal increase. Category 2, the albumin excretion rate will be 30 to 300 and albumin to creatinine ratio, it will be 30 to 300. The description will be moderate increase. In A3, there will be more than albumin excretion of more than 300 mg and ratio will be also more than 300 and it's a severe increase. And most commonly in renal stage diseases, we see A3. So this is to what you call calculate the GFR, Cockford Gold formula, where it's 140 minus age in years into ideal weight by creatinine milligram per deciliter into 72. So criteria for CKD.
And importance of the Cockrod's.
Sir?
Cockrod's formula importance.
This is to find out whenever we are in ICU, sir, we will be having these sort of investigations and we will calculate the GFR rate. And if it is more than 60, we can assess on giving antibiotics or any other drugs, where especially coming to antibiotics, the dose will be what you call decided based on GFR. So GFR is around 60 to what you call around 40 to 60 will be the GFR. Then we have to reduce the antibiotic dose to 25%. What you call out of normal dose. If say it is 4.5 gram initially, then we have to reduce it. 25% of the dose will be removed. So the 75% will be given. If it is less than around 30%, 50% of the dose will be reduced, sir. So criteria for CKD, markers of kidney damage, albuminuria, as I told, albumin excretion rate, albumin creatinine ratio, and urine sediment abnormalities, electrolyte and other abnormalities due to tubular disorders, abnormalities detected by histology, structural abnormalities detected by imaging, history of kidney transplant. So next is decrease in GFR. So markers of kidney damage, everything will be what you call can be assessed by individual. Only this history of kidney transplant, most of the patient will not be having this. So actually this cannot be included in criteria, but there is what you call some study where they're telling that even for post kidney transplant also, there will be they will not have complete normal life. So they should be having this criteria for CKD assessment for every 6 months. And if there is any abnormality, and then that rate will be increased to every 3 months. So history of kidney transplant were also included into this criteria. And decreased GFR less than 60 from categories from 3A to category 5 come under this criteria. Next thing, chronic renal failure. So commonest causes, diabetes, most prevalent in our what you call in our country: hypertensive nephrosclerosis, chronic glomerulonephritis or pyelonephritis, polycystic disease, vesico-urethral reflux, and hemolytic uremic syndrome. And other causes: lupus erythematosus, vaginous granulomatosis, congenital anomalies, vasculitis, polyarthritis nodosa, rheumatoid arthritis, gout, amyloidosis, and sarcoidosis. So these are the causes. Coming to functions, there are a number of functions which kidney does, especially it provides erythropoietin, which helps in what you call for hemoglobin, production of hemoglobin, and apart from that, it also helps in tissue oxygenation also. So kidney has direct effect on lungs, where acid-base balance are maintained. Coming to brain and heart, there is a combined effect where what you call from heart, like there are systemic RAS and central RAS, where heart also releases some angiotensin, and kidney releases renin, and liver releases angiotensin converting agents. So combining all these things, there will be increase in blood pressures and increase in salt and water retention, which I will be telling again in the coming slides. So this slide is just to show different effects of interrelation between kidney and different organs of the body. Okay. Next one. So manifestations: hematological, metabolic, cardiovascular, pulmonary, neurological, GIT, endocrine, skeletal, cutaneous, sepsis, and nutritional. So hematological manifestations: normally they present with anemia. So for CKD people, there is an acceptable range of hemoglobin of 5 to 7 gram per percentage. But when it comes to surgery point, uh, normally we prefer above 9. But when it comes to CKD patients, the cutoff point will be around 7 to 8 grams. Because we also have to consider patients, is the patient in hypervolemia state or hypovolemia state also. So we need to have a check of PCV around 15 to 25. Coming platelet and WBC dysfunction and dialysis induced hypercoagulability. So cause of anemia: there is decreased erythropoiesis, iron deficiency, increased increased RBC fragility, increased bleeding tendency, folate deficiency. Intrinsic causes: decreased sodium potassium ATPase activity, pentose phosphate dysfunction, and microangiopathic hemolysis. In this intrinsic causes, normally sodium potassium ATPase activity, what does they do? That is, they distribute the ions between intracellular and extracellular spaces, so that the what you call body system will be intact. So their main focus will be to maintain high concentration of sodium in extracellular space and high concentration of potassium in intracellular space. Whenever this activity of the sodium potassium ATPase is damaged, there will be change in concentration of sodium and potassium. There will be fluid shift. Second one is pentose phosphate dysfunction. This pentose phosphate pathway is mainly responsible for G6P synthesis, and which finally leads to NADPH release and cellular hemostasis and biosynthesis. It is the function of pentose phosphate. Once this pentose phosphate dysfunction occurs, this cellular hemostasis and biosynthesis is damaged because of deficiency of this enzyme G6PD. Hemolytic anemia most commonly precipitates. Similarly, microangiopathic hemolysis. This microangiopathic hemolysis, it precipitates because of physiological damage to the red cells, and following this, there will be occlusion of arterioles and capillaries because of fibrin deposit.
ఓంకార్ 3 పాయింట్లు మళ్ళీ రిపీట్ చేయవా?
సార్
ఇప్పుడు చెప్పావు కదా 3 పాయింట్లు. ఈ 3 పాయింట్లు ఇంపార్టెంట్, మళ్ళీ రిపీట్ చేయవా?
సోడియం పొటాషియం ATPase activity, sir. Sodium potassium ATPase, what does it do? It is we can call it an important architecture which he maintains intracellular and extracellular space ions. That is, It is the main contributor for maintaining high sodium in extracellular fluids and high potassium in intracellular fluids. Whenever this what you call ATPase activity is decreased, this the distribution of ions in particular spaces is not managed properly, because of which there will be high sodium retentions, water retention abnormalities. Second thing is pentose phosphate dysfunction. So there is pentose phosphate pathway which leads to release of G6P, and later on these give up to NADPH and ribose 5 phosphate. So these things are responsible for cellular hemostasis and biosynthesis of say amino acids or other RNA and all. So this leads to maintenance of what you call ATP reserve. Once this pentose phosphate cycle is damaged, there will be deficiency of G6P, G6PD, and because of which hemolytic anemia precipitates. Next is microangiopathic hemolysis. So microangiopathic hemolysis, this mainly leads because of interlinked to PPT, what you call pentose phosphate dysfunction only, because of which there will be a loss of integrity of the cell strength, the physical damage increases, and because of which red cells are damaged. It could be because of occlusion in the arteries or capillaries and deranged platelet aggregation also. So all these three factors are main what you call intrinsic causes for anemia in CRF patients.
Thank you.
Next, consequences. So there will be decrease in hemoglobin and decrease in oxygen content, oxygen carrying capacity, SpO2 and PO2. And coming to oxygen carrying capacity, so initially when there is decrease in hemoglobin, the oxygen carrying capacity increases. But later on, because of continuous low anemia state, the oxygen carrying capacity also decreases. And these people are prone to hypoxia because of their poor reserve, and because most of this fluid shift takes place and they're having good chance of having pulmonary edema, so their reserve is reduced. Rapid induction and emergence from inhalation agent, and what you call this when it comes to our anesthesia part, rapid induction and emergence for initial agent, inhalation agents. Whenever we are inducing a patient with inhalation agents, say as sevoflurane, so these people will be having a high respiratory rate. So the amount of drug which we are giving, its concentration increases very fast. So because gases in our lung are mainly transferred because of diffusion concentration, diffusion from high concentration to low concentration. Whenever the inhalation agent concentration increases, it easily diffuses into the cells. So patient gets what you call under easily. Coming to emergence part also, whenever there is when we are switching off inhalation agent, there is again a concentration difference which immediately pushes out all the inhalation agent until now which you have deposited, and patient recovers rapidly. And risk of myocardial ischemia, CCF, and pulmonary edema. So this is interlinked with again renin-angiotensin aldosterone systems, because of which there will be heart congestive cardiac failure, myocardial ischemia, myopathies, and so on. So how does this get compensation? So initially when there is any change in our body, there will be a compensation. Compensation by increased 2,3 DPG and shift of ODC curve to right side, and increased cardiac output by increasing its heart rate, and cardiomegaly because of the increase in heart rate. In long run they land up into cardiomegaly also. Anemia management, we see regularly patient will be on erythropoietin, but there are a lot of things we need to know about erythropoietin, iron, folic acid, and blood transfusion finally. And indications of blood transfusion, we prefer packed cell because to increase the volume overload, and maintenance of PCV will be 15 to 25%, and intraoperative hypotension or blood loss, we normally give blood. So erythropoietin, what are the advantages? Like IV or subcutaneously we can give. supplement with iron and folic acid improves HB exercise tolerance. Disadvantage: it's expensive, increases blood viscosity, risk of cerebral thrombosis and CVA, risk of thrombosis of shunt or fistula, and the patient can have convulsions, hyperkalemia, and flu-like symptoms. So whenever CKD patients present what you call with hyperkalemia, flu-like symptoms, and other conditions, so first we have to check, because out of 100 cases, 90 cases there will be an erythropoietin only. So next, coagulopathy. There will be increase in bleeding time because of decreased platelet quality and quantity, and decreased vitamin K dependent factors, factor 2, 7, 9, and 10, factor 5 and 8, and heparinization, maintain patency of stents. So they can land into disseminated intravenous coagulation, increased BT, PT, and APDT normally. Management. Hemodialysis restores platelet function, and FFP cryoprecipitate desmopressin reduces bleeding tendency also. Some electrolyte disturbances. Hyperkalemia, most commonly patients will be presented, especially if patient is oliguric, the percentage of people presenting with hyperkalemia is more. So normally what we read is 5 will be our hyperkalemia value, but some nephrologists do suggest that to consider 5.5 to 6 potassium in CKD patients as normal. Hypermagnesemia, what will happen is magnesium will be there secondary to antacids, because the antacids there will be aluminum hydroxide, and this aluminum hydroxide will be having efficiency to what you call hold the magnesium along with it when it is ingested, and decrease the renal excretion of magnesium because of especially to antacids, which normally CKD patients they will be having GI disturbances and more prone to gastritis, for which they will be taking this antacid syrups, which contains aluminum hydroxide. And aluminum hydroxide holds the magnesium with it. It does not allow magnesium to get excreted. And once this magnesium concentration keep on increasing, we can have CNS, myocardial, and neuromuscular depressions. Hypophosphatemia is also present. Whenever there is a decrease in calcium in our body, there will be an increase in phosphate concentration. So, and there is one more thing like calcium in milligram per deciliter plus phosphate in milligram per deciliter. If this sum is more than 60 milligram per deciliter, then the patient is having good chances of having metastatic calcium depositions. And most commonly, this metastatic calcium depositions occur in heart. But there is no specific evidence to say that where these deposits can occur. Coming to hyponatremia, urine loss, salt restriction, vomitings. Hypocalcemia, secondary to increased phosphate and decreased G absorption, and metastatic deposition, which I said, is most common. And for especially in cases with alkalosis, this percentage of metastatic deposition is less. But most commonly, CKD patients are in acidosis only. I don't think we can see CKD patients with alkalosis. But if there are alkalosis, there are no signs and symptoms. But otherwise, metastatic deposition is most common for them, and especially those depositions take place in heart. And metabolic acidosis, hydrogen ion retention. Most uncommon is hypernatremia and hypokalemia. So most of the disturbances, electrolyte disturbances, improve with dialysis. Coming to hyperkalemia, which is more common, factors precipitating hyperkalemia. So hypoxia, acidosis, anesthetic drugs, dexamethasone, hypercapnia, choline solution. Choline solution, it is a solution which is used for preserving kidney in renal transplant. Once the patient, once the kidney is taken from the donor, choline solution used to preserve this kidney, and later on it is again placed in the recipient's body. So this solution itself has a potassium bit of high concentration of potassium. So after what you call placement is done, transplant is done, so patients are prone to have a bit of hyperkalemia. So continuous ambulatory peritoneal dialysis itself has higher potassium concentration when compared to hemodialysis, which regularly we do. So these are some of the ECG changes. This is what you call nothing new, taken from a book only. Mild, moderate, and severe, 5 to 6.5, peak T waves and prolonged PR interval. Potassium 6.5 to 8, there will be no P wave, prolonged QRS complex, ST segment elevation, ectopic beats and escape rhythm. And severe potassium more than 8, progressive widening of QR complex, sine wave, ventricular fibrillation, asystole, axis deviation, bundle branch block, and fascicular block. Coming to treatment, so dialysis, hemodialysis washes out up to 50 milliequivalents of potassium per hour, and peritoneal dialysis 15 milliequivalents per hour, and hemofiltration and IV what you call dextrose and insulin solution. So there is what you call some studies showing telling that when we are giving insulin and dextrose solution, patient should be given some amount of bicarbonate. They suggested a minimum of 50 50 ml of bicarbonate should be given. That is, they say that when patient is having such a low sugar level, such a high potassium levels, and they are also very much prone to have acidosis. So when we are treating this potassium, we also need to correct the bicarbonate also, because when patient is taken for dialysis, if the patient's potassium is high, during dialysis, they even add bicarbonate to the circuit. So when patient is in approximately not in a range of having a dialysis, those patients should be given some bicarbonate also. But other studies deny giving bicarbonate. So it's up to our individual practice. Next is calcium gluconate, 500 to 100 milligram. And cation exchange resin. This is sodium polystyrene sulfate. Coagulate 1 gram binds to 1 milliequivalent of potassium and releases 1.5 milliequivalent of sodium. And oral dose of 20 gram in 100 ml of 20% sorbitol. So I did not use this, but it is suggested in the book, so I'm telling, but I did not use in my practice. So metabolic acidosis, most common, increase in calcium, increase in magnesium and phosphorus and uric acid, and decrease in sodium and decrease in calcium. So coming to acidosis, bicarbonate, pH and intervention. If there is moderate, we call it as moderate when bicarbonate is between 10 to 20 and pH is 7.2 to 7.3. So there is not of need of any intervention to be done. Severe, if there is bicarb less than 10 and pH less than 7.2, there should be an active intervention. Active intervention in the sense giving correction of what you call bicarb, and also checking PCO2 if needed. We go for NIV. These are all active interventions. Bicarbonate, basing on formula, 0.5 into body weight into base deficient. So the amount of figures we get, only 50% of the dose should be given, and 2 hours after again bicarb should be checked. And once there is not of much significance, the second half of the dose can be given. Okay, and still if patient's acidosis is being the same, then we can opt for bicarbonate infusion. So what are the dangers of bicarb? Volume overload, tetany, metabolic alkalosis. In severe cases, severe what you call acidosis, we opt for hemodialysis also. So cardiovascular manifestations. So what happens is, because of chronic renal failure and from kidney, RAS. What is RAS? It is renin-angiotensin aldosterone systems. uh, uh, angiotensin is released from systemic RAS or central RAS, and angiotensin is acted upon by renal, which is released by kidney, which forms angiotensin 1, and later on angiotensin converting enzyme, which comes from the lung, acts on angiotensin 1 and converts it into angiotensin 2. In the same way, from heart, also a minimum amount of renin and AC are released, because of which this angiotensin is converted into angiotensin 2. So angiotensin 2 acts on cardiac myocytes, which leads to hypertrophy and what you call this leads to vascular architecture disorders, and finally they'll end up into coronary artery disease or congestive heart failure. In the same way, because of renal failure, patients will be having hypervolemia. Why? Because the angiotensin 2, which is released, it will be acting upon what you call it will angiotensin 2 acts upon adrenal gland, which leads to release of aldosterone, which acts on kidney and also on microvasculature. And because of action of what you call aldosterone and kidney, there will be salt and water tension, and finally lead to hypertension, which further leads to cardiac issues like left ventricular hypertrophy, coronary artery disease, and left ventricular failure. And coming to microvascular cells, aldosterone causes vasoconstriction. Because of the impaired vasodilatation occurs, and it further precipitates to hypertension. So next is anemia. Anemia itself will land up into heart failure. And next one is uremia. Because of the impurities which are not being excreted properly, there will be pericarditis, which leads to congestive heart failure, and directly cardiomyopathy can occur. And next is there will be increased triglycerides and decreased HDL, and atherosclerosis can also take place. These things leads to coronary artery diseases. So these are the reasons why a patient with renal failure land up in having cardiomyopathy, coronary artery disease, and heart failure. So cardiovascular manifestations, just explaining what I have shown in the chart. Hypertension is refractory 15%. How do we manage? Salt fluid restriction, beta blockers, clonidine, methyl dopa, hydrolysine, calcium channel blockers, hemodialysis, and finally nephrectomy. Coronary artery disease, congestive cardiac failure, and CV also. Painless pericarditis and pericardial effusion. So painless pericarditis and pericardial effusion, these can be dealt with dialysis about a week, and intrapericardial steroid injection, and finally pericardiectomy. Increased risk of myocardial ischemia, infarction, arrhythmias, vascular calcification, accelerated atherosclerosis. These are all serious manifestations. Coming to pulmonary infections, atelectasis. Why atelectasis? Because of what you call effusion, peripheral areas will not be ventilated properly, and they can land to atelectasis. Pulmonary edema and uremic lung. There is alveolar interstitial edema, hyperventilation, COPD, emphysematous changes, restrictive lung diseases, posture and alteration in pulmonary function test, and elderly patients. Neurological manifestations. So most common neurological manifestations are because of high amount of what you call blood urea levels. So general irritability, fatigue, and depression, autonomic neuropathy, peripheral neuropathy, tingling, numbness, paresthesia, pain in extremities. Median nerve and peroneal nerve are most commonly involved, resulting in restless leg syndrome. Myopathy, muscle weakness and muscle twitches, dementia, aluminum toxicity in dialysis fluid and antacids, convulsions, cerebral edema, encephalopathy, lethargy, confusion, seizures, and coma. And sensory deficits are very much rare. GI manifestations, anorexia, nausea, and vomiting, acidity, ranitidine is preferred, slow gastric emptying, so risk of regurgitation and aspiration, ulcers, gastric and duodenal, avoid aluminum or magnesium antacids. GI bleeds, aluminum and magnesium, these are avoided because of electrolyte disturbances also. GI bleeds, paralytic ileus. So endocrine manifestations, secondary hyperparathyroidism, glucose intolerance, hypertriglyceridemia. Hyperparathyroidism seen secondary to hypocalcemia and hyperphosphatemia. So what happened with this? There is bone decalcification and high risk of getting fractures, osteodystrophy, metastatic calcification, skin and joints, but most commonly it is heart pruritus. Skin manifestation, osteodystrophy, periarticular calcifications, prone to have fractures. Skeletal manifestation, osteodystrophy, periarticular calcification, prone to have fractures. Careful handling and positioning is needed. So cutaneous manifestations, hyperpigmentations, ecchymosis and pruritus. So most of CKD patients, nape of the neck and below the orbit, these are the common areas where pigmentation is seen. Coming to sepsis, uh, most common cause of death in CKD patients and increased risk of infections. Why? Because of decreased immunity, immunosuppression, steroid therapy, serum hepatitis following dialysis. Uh, when patients, CKD patients, if they are diagnosed to hepatitis, their attendance also need to be checked. 6 month screening should be done. TB very common, though they are not having any chest complaints. TB is very common in these patients. Viral atypical infections, cytomegalovirus, mycoplasma pneumonia, legionella pneumonia, influenza pneumonia. And whenever we are handling or doing any procedure for a patient, complete septic protocols should be followed. So dietary considerations: high calorie, that is 90% calorie, and 1 liter D50 plus 40 to 60 international units of insulin per day to maintain sugars approximately 200 below 200. Salt restricted diet and essential amino acids to be provided. Parenteral, albumin 0.5 to 0.8 gram per kg per day. Glucose is better than fructose and sorbitol in intralipid. Okay. And if patients on daily hemodialysis, replace potassium and maintain sodium 130 to 135, and check for serum phosphate twice a week or weekly, twice a week, and zinc and magnesium weekly. So replace water soluble vitamins lost during hemodialysis. Folic acid supplementation. Fluid 0.5 liter plus daily urine volume if patient is passing urine, because some patients don't have severe anuria. So for them, we have to add the urine which is being produced also. Fluid loss in hemodialysis, 2 liter per day for hemodialysis, and peritoneal dialysis 1 to 2 liter per day. So normally, when we are taking a CKD case for any surgery, so these are the drugs which normally they will be taking: antihypertensives, beta blocker, calcium channel blocker, steroids, antibiotics, immunosuppressants, antacids, H2 blockers, digitalis, antiarrhythmics, diuretics, bronchodilators, insulin or oral hypoglycemics, heparin, aspirin, bicarbonate, calcium, and iron, folic acid, and vitamin B12. So chronic hemodialysis. So hemodialysis is obviously having a benefit when we are dealing with CKD case, but there are some problems. Mostly repeated dialysis, mostly prone to hepatitis B infections, hepatitis C also. But hepatitis C is most common. Next is decreased pseudocholinesterase levels and prolonged gastric emptying time during dialysis. Okay, that is 300 minutes in uremia, 700 minutes during dialysis. But normally for gastric emptying, it takes around 90 minutes. Psychological disturbances, infections, chronic refractory ascites, hypersplenism, rebound heparinization. So rebound heparinization, it takes around 6 to 12 hours post dialysis, in which there will be increase in all the what you call clotting factors for post dialysis. And once we are taking any case to what you call surgery, we do write heparin free dialysis. So in most of the setups, what it happens is because there will be an obstruction to the flow if they are doing heparin-free dialysis. So they are forced to push a minimum amount of heparin into the system to prevent this what you call flow disturbances. So always we need to have one coagulation profile of before the posting for surgery, and there too a minimum of 6 to 12 hours gap should be there of should be there before we are doing dialysis and we are doing the blood test. Chronic hemodialysis. So what dialysis cannot correct? Refractory hypertension, pericarditis, osteodystrophy. And what new with dialysis? Dialysis disequilibrium syndrome. Dialysis patients on dialysis of more than 5 to 6 years, they'll be having headache, nausea, vomiting, muscle twitching, convulsions, coma, and in severe cases, they will end up into death. Prevention: frequent short duration and slower dialysis. So nowadays, most of nephrologists are also even what do you call it? Previously, they used to have every alternate dialysis, but they are trying to reduce the number of dialysis because of this increasing disequilibrium syndrome cases. But when clinical condition is not good, they are left with no option. They have to go for dialysis every alternate day. So indications: fluid overload. So indications for dialysis: fluid overload, hyperkalemia, severe acidosis, high serum creatinine, raised blood urea that is more than 300 milligram percent, metabolic encephalopathy, drug toxicity, and worsening condition despite treatment. So pre-op investigations: hemogram with complete counts, urine analysis, electrolyte, sodium, potassium, calcium, magnesium, and chloride, blood sugar, fasting and postprandial, kidney function test, blood urea nitrogen and creatinine, coagulation profile, LFT, arterial blood gas analysis, acid-base status, X-ray, and ECG. And coming to ECG role, by looking into ECG, we can predict some electrolyte imbalances or arrhythmias. If it is distalis, patient on distalis or distalis toxicity, we need to look for T wave changes. That is, it could be flattening or inversion, or else peak T waves can be present with a short QT interval. And ischemic changes, T inversions, and hypertensive heart diseases, mostly they'll be having a bundle branch block or hypertrophy, tall T waves. These are some of the changes which can see in ECG. When these changes are seen, then it's better to opt for 2D echo. So 2D echo is also what you call doing 2D echo for CKD patients depends upon the duration, from how long patient is on what you call dialysis. And if patient is recently on started on dialysis and there are no ECG manifestations, we can what you call skip 2D echo also, basing on the surgery also. So we have to plan 2D echo if there is a long duration surgery, long duration of hemodialysis, and other systemic manifestations also. But in our routine practice, we regularly go for 2D echo. But according to theory, these are the things which we have to consider before we are doing 2D echo. Pre-op preparation: evaluate latest reports, especially we are worried about potassium. Consider present drug therapy, that is insulin and steroid doses and anti-hypermedications and all. Limited time available for correction of anemia, acidosis, fluid, and electrolyte balance. And all peripheral vein thrombos are used up. IV line in contralateral saphenous vein. So why contralateral is we always need to reserve one vein for hemodialysis. If HD within 24 hours, hypovolemia, HD greater than 2 to 3 days ago, hypervolemia and risk of pulmonary edema. So what he means to say is, so when is last hemodialysis done, and what is the ultrafiltrate level removed, and check patient status what you call before surgery again, and respiratory system examination, pulmonary function test. These all need to be done before we are opting for surgery. So, regardless of the procedure or technique, ensure optimization of uremic manifestations. Factors altering drug action in renal failure, anemia, hypoproteinemia, electrolyte disturbances, body fluid relocation, acidosis, abnormal cell membrane activities, impaired mechanism of biotransformation, generalized depression of all enzyme systems, decreased renal excretion, altered blood-brain barriers, intrapulmonary shunting, uremia, and CNS depression. So, normally, pre-medication drugs, I'm not going to details of everything, but focus on morphine and pethidine. So morphine, more chances of having respiratory depression, so better avoid. Pethidine, CNS excited seizures, avoid. Fentanyl, sufentanil, alfentanil, remifentanil are safe. So intraoperative monitoring, ECG, non-invasive, if not intra-arterial BP, if not intra-arterial BP, then go for NIBP, SpO2, EtCO2, CVP, electrolytes, ABG, temperature, blood loss, fluid input and output balance, and blood sugars. So these are all the points which you have to be keen on. Intra-arterial blood pressure in case of renal transplant and any major surgeries. So anesthetic technique, pre-oxygenation advocated because there are good chances of immediately patient having hypoxia because of decreased reserves, rapid sequence induction, and IV induction, pentothal, propofol, fentanyl, midazolam, and intubation depolarized if no contraindicate, especially because it is decided upon potassium values and also pseudocholesterol levels. So most commonly it will be on higher side. So what do you call non-depolarizing agent is preferred. And the next narcotic, fentanyl and neurolept is safe. And abolishing stress response to laryngoscope and intubation, IV fluids with care, and atracurium, vecuronium, rocuronium, pancuronium, they can be used, but the decision to be taken based on time of the surgery, and these are intermediate acting drugs. So with cautious we have to give.
Evgamar, can you mute yourself? Evgamar.
Hello. Hello.
Yeah, Uncle.
Sir, can I continue, sir? And reversal with atropine or glycopyrrolate and neos treatment. So these are tables which we need to see regarding induction drugs, reversal drugs, anti-cyanocox and all. So thiopental, for when we are using thiopental, 60 to 50% of these drugs, they bind to albumin. So CKD patients are mostly prone to have less albumin. Okay, so there will be an increase in duration of action of thiopental. So we have to reduce the dose. Okay. Next is propofol. It is safe. We can use it. Ketamine, metabolites are excreted in urine, and it also causes hypertension. So ketamine is avoided. Etomidate and droperidol. And I have never used this droperidol for induction agent. This was given in flowchart in 2019 article, I guess, 2019 article. Next, inhalation agents. Coming to inhalation agents, there is no nephrotoxicity with halothane, isoflurane, desflurane. Sevoflurane, there is a concept of compound A and compound B, and compound A being nephrotoxic. But in new Miller's edition, it was mentioned that there is no such risk with compound A correlating to nephrotoxicity. We can use sevoflurane in CKD patients also. And enflurane, nephrotoxic, and for long duration cases. And methoxyflurane, highly nephrotoxic, it is to be avoided. Muscle relaxant. And succinyl choline, mainly it causes hyperkalemia, and it's only dependent upon pseudocholesterol levels. So before giving this, we need to check both of potassium levels and pseudocholesterol levels. And what if we are giving scoline, the longer block in ESRD and uremia cautiously used in hyperkalemia. So these two things. So he's also suggesting to reduce the dose. If it is a difficult airway, now, though we are having rocuril nowadays, previously they used to use 50% of suggested dose of scoline. Atracurium, mevacurium, all these drugs are they can be used. And coming to vecuronium, rocuronium, their duration is prolonged, because vecuronium 30% is eliminated through renal only, vecuronium, rocuronium, pancuronium. So these drugs to be given cautiously when we are using in CKD patients. They are not contraindicated. They need to be used with caution. That's all. Coming to anticholinergics, atropine, atropine and glycopyrrolate, 50% excreted by kidney only. So single dose usage is safe. So scopolamine, even though we are not using it, it's better to avoid because it increases CNS effects. Anticholinesterase, neostigmine, it is 50 to 70% excreted in urine, and it is prolonged T-half, and duration of action is also increased. But it is safe, useful even with long-acting NMDS also. So though we are dealing with neostigmine daily when recovering the patient, and though it is 50 to 60% excreted in urine only, it can be used, because the other neuromuscular agents which we are using, their action is also prolonged. So these neostigmine, if this dose is action is prolonged also, they will be capturing more and more number of NMDA receptors, which will be helpful to us to recover the patient. So only thing we need to check when we are giving these neostigmine doses is after recovery, any increase in secretions, any pulmonary edema. So these are the things we have to watch for. Next thing is vasopressors, because of our induction agents, there will be, because most of the people are now very much commonly using propofol. So there are good chances of having hypotension also, and in especially cases of CKD, kidney transplant and all. Initially, we need, until transplant is done, we need to maintain blood pressure between lower set and not too low, because when the clamping and everything is done, BP falls down. In those times, we need to supplement with either fluid or else vasopressors. So which vasopressors are safe to be safe and which are not? Epinephrine, norepinephrine, they are predominantly having alpha action and decreased renal blood flow. So care, we need to be cautious when we are giving this. Isoprelane, and when given in high dose, it dominates. It has alpha action. In low doses, it will be having beta action. Myocardial irritability is present and maintains renal blood flow. Dopamine is safe, and because dopamine is dose adjusted up to around more than 20 microgram per kg per minute, alpha action predominates. Less than 10, beta action is predominant, and in this less than 10, it is safe on kidney part. Dobutamine, angiotensin, these are more of alpha action and decreased renal blood flow. Phenylephrine also has alpha action and decreased renal blood flow. And PGE2 alpha, it has more of beta action, and natriuresis is more common. So input-output fluid therapy, aim in patients who are chronically volume depleted and hypervolemia, need to maintain good output, maintain CVP of 8 to 10 centimeter water. Maintain systemic blood pressure of 100 to 130 mmHg. Sorry, systolic BP of 100 to 130 mmHg. Advisable fluids, crystalloids, and PRBCs. Potassium containing solutions should be avoided. Post-op hemodialysis if you think patient is hypervolemic. So anesthesia for shunt and fistula, preferably give block. It helps a lot. And precautions: care due to coagulation problems. What do you call debilitation? Smaller dose of local anesthetic. Increased myocardial irritability, acidosis, increased potassium, and increased input volume. Avoid epinephrine in local anesthetic. Risk of increased systolic blood pressure, renal vasospasm, decreased renal blood flow, arrhythmias, and ST changes. Vasoconstriction makes fistula or shunt formation or cannula insertion more difficult. So shorter duration of action of local anesthetic in uremia, almost 38%. So we need to reduce our local dose also. Better avoid giving 2%, dilute it to 0.5, which is very good, or else 1%. So care of fistula. Cover it with light bandage. Do not apply BP cuff on the hand where fistula is done. Do not cannulate vein or artery on that side. Do not inject. Hypotension can block the fistula or shunt. Allow adequate circulation in that arm. Do not flex or overextend the arm for your surgical procedures. Be cautious when we are doing that. One more thing is renal replacement therapy, which is hemodialysis or peritoneal dialysis. Hemodialysis, we pick up a vein and an artery. And peritoneal dialysis, it is the catheter will be in the peritoneum. The fluid will be ingested into the peritoneum, and again fluid will be collected back, which is draining out all the impurities from the peritoneal space. So what are the differences? So peritoneal dialysis, its rate of clearance is slow, whereas hemodialysis is fast. In hemodialysis, we can adjust flow rate and everything. I'm not talking about that rate. The amount of purities which will be cleared by peritoneal dialysis is low, with hemodialysis is more. Location: initial peritoneal dialysis can be done in hospital setup. Other dialysis can be done at home itself. Hemodialysis, hospital setup is preferred because there are good number of chances having hypoglycemia and hypotension also. Ultrafiltrate osmotic pressure via dextrose dialysate, and for hemodialysis, hydrostatic pressure. Solute removal, concentration gradient and convection. Concentration gradient and convection. Both the formula for removal of the impurities are the same. Here the membrane is peritoneum, whereas in hemodialysis, semi-permeable artificial membrane, which normally we can see for that, which will be attached to that dialysis unit. Blood will be flowing through that permeable membrane, purified, and again it will be pumped back. Method: indwelling catheter in peritoneal cavity. For hemodialysis, line from vessel to artificial kidney. Complications: for peritoneal dialysis, infection at catheter site, bacterial peritonitis, metabolic effects of glucose, difficult to achieve adequate clearance in patients with large body mass. Whereas in hemodialysis, vascular access, bacteremia, bleeding due to heparin, hemodynamic stress of extraperitoneal circuit, disequilibrium syndrome, which leads to headache, cerebral edema, hypotension, nausea, muscle cramps related to solute or water flux over short time. Preferred when peritoneal dialysis, if the patient is young, high functioning, with residual renal function, success depends upon presence of residual renal function. Whereas hemodialysis, if the patient is bedbound, large number of comorbidities, no renal function residual, renal function not at all good. So normally what they do is, if patient with less number of comorbidities and young age, they suggest peritoneal dialysis. For other conditions, they obviously go for hemodialysis only. And some more pros and cons of hemodialysis and peritoneal dialysis. Pros, predictable ultrafiltration with each session, frequent evaluation of volume status by healthcare provider, variety of therapeutic interventions to manage intradialytic hypotension. Cons, hemodynamic instability, particularly in presence of ventricular dysfunction, myocardial stunning with aggressive ultrafiltrate. Peritoneal dialysis pros, gentle and sustained fluid removal, better preservation of residual renal function, and ability to use cardioprotective medications with low risk for hyperkalemia. Cons, precise predictable prediction of daily ultrafiltration volume not possible. So this is the drawback. We just dump in fluid and we remove the fluid. We do not have proper control in peritoneal dialysis. Greater dependence on patients to adjust prescription in response to daily fluctuations in fluid status. So only what you call this thing is it can be done at home setup, and less number of hypotension during peritoneal dialysis, and cardioprotective medications they can be used. Whereas in hemodialysis, we need to be cautious when patient is on hemodialysis. What are the medications which they are taking, say hypertensive drugs or hypoglycemics or insulins? We need to check all these things, and we need to give proper instructions either to cut down antihypertensive on the day of dialysis or hypoglycemics. Whereas in peritoneal dialysis, there is a liberty to give them drugs and proceed for the dialysis. Thank you all. Hello.
Thank you, Omkar.
Thank you, sir. I think it's been too long.
Yeah, but it's you have explained everything. I just have only 2-3 questions. One, you said new Miller edition, you have provided the data of something, and second thing is that it is the individual choice of giving a soda backup. That's the one, 2 things I just want clarification, because I mean, if we are talking about it, there should not be any individual choices of soda backup giving, because somebody gives, somebody doesn't give. If you have the proper reasoning, that's enough. For this
Yes,
new
sir.
inhalational, you said new edition. Okay, that's fine. Which edition is the new Miller is recently come?
I said actually this was suggested by Chaitanya only.
Okay.
She only told, and I think I have a clipping of that paper picture also. I will forward it, sir.
Thank you very much. Very good explanation and understanding. So maybe you can post the slides to the group. Thank you.
Okay, sir. Okay.
Hello.
Madam, good morning, madam.
Morning. Omkar, nice class and a lot of physiology of renal function. That's very nice. Mohan sir.
Madam.
Sir, మీరు అడిగిన బైకాప్ దానికి like renal conditions are exceptions, sir. Like other indications of bicarb in acidosis and sepsis, they are the different things, but renal failure low, irrespective of pH and all, many times in severe acidosis, hyperkalemia and all those things, nephrologist many times they give small dose of bicarb bolus and start bicarb infusion like 10 to 15 ml per hour alaga maintain chestuntaru, and that's the only
నేను అనేది ఇండివిజువల్ చాయిస్ అనొద్దు, అది ఇస్తారని అంతే, ఇవ్వద్దని కాదు. ఇండివిజువల్ చాయిస్ అని చెప్పాను అంతే.
Yeah, individual choice, but only in renal cases like they justify nephrologist, like it is advised అని అంటారు. మనం మామూలుగా అందరికి ఇవ్వం కదా. Like we used to say below 7.1, now they say below 7 or below 6.9, something like that. But this is renal conditions are exception. They give even if it is 7.1 or 2.
కార్డియాక్ సర్జరీ తర్వాత కూడా ఇస్తాం కదా మేడం, వీళ్ళు 7.3 ఉన్నా కానీ.
సార్ ఎప్పుడు సార్
కార్డియాక్ సర్జరీ ఇస్తారు కదా మేడం రోజు రెగ్యులర్ గా, అందరూ చెప్పాలి మరి రీజన్.
సార్ వాళ్ళ రీజనింగ్ వాళ్ళు చెప్పాలి. ఐ డోంట్ నో. యా, సో బట్ దిస్ ఈస్ వాట్ ఐ నోటీస్డ్ రీనల్ వాళ్ళకి. అది Good
Madam, one small thing,
presentation.
madam.
Chep.
Madam, are we giving bicarb, madam? Ante potassium high levels ఉన్నప్పుడు we normally give insulin dextrose challenge కదా madam.
Insulin dextrose, calcium, bicarb, nebulization, all these are methods.
Okay, madam.
ఒక్కొక్కసారి చాలా హై ఉంటే we give everything. And nebulization like back to back 2-3 times కూడా ఇస్తాము.
ఓకే, అంటే ఇక్కడ ఒక లైన్ లో చూసాను మేడం, నేను ఏమని ఇచ్చారంటే లైక్ వీఆర్ యాడింగ్ D50, వీఆర్ టేకింగ్ D50 ప్లస్ 10 units of insulin plus 50 ml bicarb. It is their protocol which they are following.
అయిపోయింది కవర్
Yeah,
ఆడిపోయింది ఎసుగు ఇచ్చే
bicarb,
ఇచ్చేస్తే
calcium gluconate
Madam, your voice is.
దాంట్లో 25D లో before you do that you have to check add in.
మళ్ళీ రిపీట్ చేయండి, మీ వాయిస్ కట్ అయిపోయింది.
Omkar, ade 25D with insulin 10 to 12 units. Before you give that, we have to check blood sugar levels. దాన్ని బట్టి ఇన్సులిన్ యాడ్ చేస్తాము. అండ్ అదర్ థింగ్స్ యాజ్ యూ సెడ్ 50 bicarb and calcium gluconate 10 to 20 ml and nebulization. Nebulization, we don't need the steroid one, we just need a aspirin nebulization like 2-3 times. ఇవన్నీ ఇచ్చిన తర్వాత మళ్ళీ you have to check the potassium levels.
Okay, ma'am.
Okay, thank you, Omkar. Thank you, nice class. Thank you all. Bye.
Thank you, madam.
Omkar, you told the common cause of death in CKD is infections, but I think it is sudden cardiac death.
Sir, hello. Sir, lot of disturbance, sir.
Cardiac death is the common cause of death in CKD.
కామన్ కాజ్ ఆఫ్ డెత్ నువ్వు ఇన్ఫెక్షన్స్ అని చెప్పావు, ఇట్స్ కార్డియాక్ అని చెప్తున్నారు సార్.
ఓకే సార్, ఓకే.
హలో
సార్, రామన్ ప్రసాద్ సార్ చెప్పిందని ట్రాన్స్లేట్ చేసి. కామన్ కాజ్ ఆఫ్ డెత్ ఇన్ సిఆర్ఎఫ్ ఇన్ఫెక్షన్స్ కాదు, కార్డియాక్ అని చెప్పి చెప్తున్నారు సార్.
అవునా, ఓకే ఓకే.
Sir, I will again recheck and I'll get back to you, sir.
Sir?
అది ఒకసారి మళ్ళీ రీచెక్ చేసి చెప్తాను సార్. అంటే వాట్ దే సెడ్ ఇస్ అండర్లైయింగ్ ఇన్ఫెక్షన్ అండ్ లాంగ్ రన్ లోని దాని వల్ల వస్తుందని ఇచ్చారు. ఆబ్వియస్లీ ప్రెజెంటేషన్ ఈ కార్డియాక్ మేనిఫెస్టేషన్స్ తోటి డెత్ అవుతుంది. బట్ the trigger point of all these things will be one from the kidney side and second from the sepsis side, sir.
So one question for
heart failure yanni kidney manifestations vastayi sir. They will be aggravated because of sepsis.
Usually they get admitted with acute on CKD, Omkar.
Yes,
yeah, that's sepsis acute on CKD to ICU lo ekku admissions untayi. From the complications of that they die.
Okay.
One question for DNP students. In the history, you should always look for the last date of hemodialysis. And if a CKD patient posted for BK amputation and pre-dialysis and post-dialysis weight is more than 2 kg, what problem you anticipate during anesthesia?
Hello, sir. Sir, repeat, sir. Last date of hemodialysis we will ask. After that, sir.
The pre-dialysis and post-dialysis difference of weight is more than 2 kg.
Okay, sir. There is more amount of fluid have been removed, sir. Might be ultrafiltrate, too high ultrafiltrate.
Yes,
2 kg,
patient
2
is
kg less or 2 kg
hypovolemic.
more, sir?
Less.
Less only, no, sir. అది తగ్గుతాడు కదా సార్ అలాగా అదే ఇట్స్ అన్ హైపోవోలిమియా స్టేట్ లో ఉన్నాడు సార్ పేషెంట్.
So you should hydrate the patient before
sir.
giving anesthesia.
Okay, sir. Okay.
What is the definition of end-stage renal disease?
Definition of end-stage renal disease, sir.
Estimated GFR is less than 15 ml per kg per minute.
Sir, with the duration of more approximately 3 months or more, I guess, sir.
అది క్లాస్ లో క్రైటీరియాలో చెప్పాడు అనుకుంటా.
Sir, yes, sir.
జిఎఫ్ఆర్ చెప్పినప్పుడు చెప్పాడు.
What are the ultrasound findings of CKD?
Sir, grade 2 or 3 parenchymal changes, shrunken kidney, more what you call deranged architecture of kidney surface area. Most commonly nodules will be present. If any cyst can also be present.
Loss of corticomedullary differentiation also.
Okay. Loss of corticomedullary differentiation. Okay. Any more questions, sir?
Thank you, Srikanth. Thank you, Omkar.
Thank you, sir. Thank you all for spending so much of time.
Slide competition.
Sir. Thank you, sir.
చాలా బిజీ ఉంటాయా? ఎందుకంటే రేపిడ్ ఎందుకు తగ్గింటది? రేపిడ్ ఎందుకు తగ్గింటది? ఏంటి